All right, this is part 4 of the urinary lecture. So we're going to stop right here on this slide for a little bit. We're going to talk about some hormones. And these are listed in your textbook on page 587 and of the A&P textbook. And so with these hormones, we first off have the antidiuretic hormone. We've already talked about that a little bit. And how that regulates our blood pressure. So your diuretic hormone senses the need to hang on to your water if our blood pressure is low. Antidiuretic hormones made in the hypothalamus. And it's secreted by the posterior pituitary when our blood pressure decreases, or if there's an ion concentration decreases. So ADH actually increases the permeability of the distal tubules and the collecting duct. And so by doing this, more water is held onto and reabsorbed, so that helps get the blood pressure up. And of course, if we're holding on to more water, we're going to be making less urine. Our blood volume will increase because we're hanging on to some extra water. Osmotic concentration will decrease, and this will help our blood pressure to rise. And also remember, alcohol and caffeine inhibit that antidiuretic hormone, and so with that it will increase your urination. And again, if you've been drinking alcohol, then this is kind of like a double whammy, because when you've got a hangover and your body is peeing off a lot, getting rid of a lot of urine, and that aids into that dehydration feeling. And with alcohol, you're supposed to, if you consume alcohol, consume on, make sure you have food in your stomach, or alternating liquids. 1 4-ounce serving of alcohol with 4 ounces, or even more, really, probably 8 would be better, of water. Helps keep you less inebriated, while also helping with your imbalance. Okay, next up is aldosterone. Aldosterone helps to increase blood pressure, and the aldosterone is secreted by the adrenal cortex, and it causes it's secreted when plasma sodium decreases or plasma potassium increases. And of course, if we're increasing our sodium, we're hanging on to the sodium, then that's going to help raise our blood pressure. So the aldosterone helps to increase our blood pressure with sodium being reabsorbed. And if sodium is being reabsorbed, what's happening to our urine? Yep, you got it. Urine output will decrease. All right, next up is the atrial natriuretic hormone, ANH. And this one helps to decrease our blood pressure. So this is the only one of the 4 that actually decreases blood pressure. It's secreted in the atria of the heart when blood volume increases. And what it does, it helps, the ANH helps decrease sodium reabsorption. And so if we're getting rid of sodium, again, what follows salt? You got it, water. Water follows salt. And that will help decrease our blood pressure. All right, the last one is a renin angiotensin 1, angiotensin 2 dash aldosterone. And this is kind of a chain reaction in 3 different systems, the kidneys, the lungs, and the liver. And so when our body, when your kidneys detect a decrease in blood flow to the kidneys, we've got some special cells near the glomerulus called the juxtaglomerular apparatus. And so when it senses a decrease in blood flow, it secretes renin into the bloodstream. The renin then converts into angiotensin 1, which is a protein made by the liver, into angiotensin 1. Then an enzyme made by your lungs, an angiotensin converting enzyme ACE, converts angiotensin 1 into angiotensin 2. Angiotensin 2 has several different effects. It increases thirst. It increases the antidiuretic hormone secretion. It increases aldosterone secretion. It causes vasoconstriction. And again, with vasoconstriction, we have a rise in blood pressure because there is of a higher fluid volume. So our blood pressure increases through this chain reaction and holds on to more fluid, and thus raises our blood pressure. Okay? All right, let's see. Moving on. Next slide, we have. All right, let me take just a quick moment to remind you to please read over the diabetic nephropathy clinical application on page 381. If you haven't noticed, I do get test questions out of these little secret boxes, and you should really pay attention to them, okay? All right, so your bladder is a hollow organ. It's posterior to the pubic symphysis. Of course, it has rugae, so it can stretch and hold more urine when we're driving and we can't, there's nowhere to stop and pee. Helps us get to that next stop. The bladder has a muscular wall. Some elderly considerations with the bladder: decreased elasticity of the bladder, muscle weakness in the bladder, and also the ureters. So in essence, we can't hold as much urine, and because our muscles are kind of weak, we may have some incontinence, and it could be from stress incontinence, or it could also be from just lack of strengthened muscles. And so one way we know to help strengthen the muscles, pelvic muscles, is Kegel exercises. Kegel exercises are for men and women. They're good for both of us to keep those bladder muscles strong to help prevent incontinence. So keep that in mind. Let's see, got you some questions here to answer. And so make sure you do those, and we'll go over the answers to these questions in Zoom meeting next week. Okay. Let's see. We have also we have our sphincters in this picture. This little triangle area right here is called the trigon. And so when you're actually putting in a Foley, you're going to put it, into the urethra, and once it gets to that trigon area, you will see some urine flow out, and so at that point you want to advance it another inch or two to make sure that you're in the bladder well, and then you want to blow up that balloon, okay? Because if you start getting some urine right here at this point and you start blowing up that balloon, that's going to stretch that urethra, and your client is going to scream because it's very painful. Okay, so that's why you always advance it, the Foley catheter tip, another inch or two, so that you know that you're in the bladder, because when you blow up that balloon, it's about the size of a quarter. When you blow it up, that 10 cc's of sterile normal saline that comes in your Foley kit. And so that's a pretty, quarter size is pretty good size. And you would definitely would not want that down in the lower part, in that trigon, or even a little lower, might accidentally, get that into that urethra. And you can imagine something that is teeny tiny, smaller than an average straw, being stretched like that. Very, very painful. And again, like I said, your patient will scream at you. And I think I would too. Okay. The urethra, urine leaves the bladder by the urethra. Length, women's our urethra is shorter than men, and that is why women have more commonly can have a urinary tract infection. UTIs are a lot more common in women because women's our urethra is shorter than men's. Now, that urethra can get inflamed. It's called urethritis, and the urethra can get inflamed, men and women both, if we get some bacteria in there. And bacteria we think of potentially from a urinary tract infection. Also, with our elderly clients, we want to make sure we're teaching them correct wiping process. We wipe from front to back. With females, again, it's very easier for us to get a UTI. We've got to be very careful when we're wiping. Make sure none of the stool, which of course has bacteria in it, gets into our urethra, and then of course up to the bladder, and causes us to have a urinary tract infection. Okay, another cause of urethritis is STDs, STIs, sexually transmitted diseases like gonorrhea or chlamydia. Okay, so got to be very, very careful with our bodies. Also, we're going to think about here too is bladder control. Children with their bladder control, initially they have no control of their bladder. About the age of 2, children start having good bladder control. Now, yes, some children train a little sooner than that, 18, 19 months. But about the age of 2 is when we have children can control their bladders. Now, and this is not me picking on the guys, but your textbook, and I've experienced it in real life, boys do seem to take a little longer. The book doesn't really say why. I don't know if it has something to do with the attention span, but I've read a lot of good things too about how to get your boys to, pee. We've read things like put some Cheerios in the toilet and try to sink the Cheerios, have a little boy pee on the Cheerios to make them sink, or sometimes just as simply as letting them pee outside in the backyard where not the whole neighborhood can see them. Um, but that's another option, because when you pee outside, it makes bubbles on the ground. And so that's potentially another way to help boys with toilet training. So let's see. Again, let's see our elderly considerations here. We're looking at, of course, that prostatic hypertrophy that we talked about earlier in the lecture. Increases as well and can cause bladder retention, can cause the stopping and starting of the urine flow. And so that's another consideration with our urethra. Okay, so if we do not have good kidneys and we have to do hemodialysis. This is what a hemodialysis system might look like. And these are surgically implanted. This one right here is called a Quinton catheter. And again, only people that have been specially trained can access and use these. As you can see, this catheter goes directly into the heart. Okay, so it is not something that you should handle or use unless you are specifically trained and to do so and are authorized. Typically, LPNs are not trained to do this. So be sure you know your rights and responsibilities as a nurse. Okay. Now this is for hemodialysis. Both of these are for hemodialysis, blood dialysis. Let me stress that again, hemodialysis. And I have a video here of a lady, and it shows them accessing and the process of hooking up these to the dialysis machine. And so very cool video. I think you'll really like it. Another option, and this is the one that is used in the video, is a fistula. And these are fistulas. They are implanted into the person's arm. And you'll see there's a lady on the video and a gentleman too that you can really see their fistula. And so it should stand out quite a bit to you. But it's like I said, it's very good to watch, and I hope you do, because I think you'll enjoy it. Kind of gives you an idea, because unless you work in a dialysis unit or you've seen it done in the hospital, you don't really have any idea of what goes on. So very good video, and I highly encourage you to watch it. Okay, next slide. This is a peritoneal dialysis, and we talked about peritoneal dialysis when we were in GI. And so we have this video here, video link for the peritoneal dialysis. Initially, what happens is, in this bag system is how it is manufactured and packaged, and hospitals have these. But just a few years back, when I was doing peritoneal dialysis, occasionally on a med-surg floor, there was two different solutions, two different compositions of solution, and it depended on the patient's lab work for the morning, which solution the physician would choose to use. And so after the physician made that determination, again, we would do the peritoneal dialysis. We would first drain the peritoneal cavity. We'd drain all the fluid out. And you can, in the hospital setting, you can look and see how much was put in, and it should be, I believe these bags were 2 liters, but don't quote me on that. But you should get out whatever the last person charted that was put in, okay? And so if you're not getting as much output as the patient as it is recorded in their chart, then have the patient turn from side to side, manipulate, move about. Generally, that turning will help get the rest of that excess out. And so once you've gotten all of it out, there's clamps in here to clamp it shut. This is weighed and is charted as a weight, okay? And after this is all clamped off, this is clamped started, and the fluid runs in. Now this right here is what is outside of the person's body. Kind of looks a little bit like a peg tube if you've seen one of those, but it's a little tube that comes out of the body. This is very, very sterile. And so if you're doing this on the med-surg floor, this is a sterile procedure, and your patient would be wearing a mask. There is a cleaning solution that the physician orders that this to be cleaned with, and there is also a sterile cap. So when you start this, you would remove, you would both have your mask on, sterile gloves. The nurse would uncap this, clean it very well with the solution, hook this tube to it, and once that is hooked together, then you can take your masks off, and we would drain it first, and then we put in the clean new solution in. Again, sterile procedure when you're hooking and unhooking it only. Okay? Okay. All right. And good deal. I have a little bit of another slide of the dialysis coming up. So I'm going to stop here, and I'll start again here in a few minutes. Thank you much.